네, 지금부터
We will now begin Global Korea Convention 2020 K-Quarantine and Healthcare Session. I am the president of Korea Institute for Health and Social Affairs. My name is Cho Hung-sik. Let me say a few words as an opening remark. Good afternoon. We are having the 3-day Global Korea Convention 2020. We're dealing with the topic K-quarantine and healthcare. I am the president of KIHASA. I would like to thank the Minister of Health and Social Welfare. He was supposed to come, but instead, Mr. Ko De-kyung from the ministry is going to read his remark on the minister's behalf. I would like to thank the officials from the Ministry of Health and Welfare for coming to the conference, and also I'd like to thank the two speakers and the three discussants in advance. This year's Global Korea Convention 2020 deals with world peace, prosperity, sustainable development, and as Korea is enhancing its national image and status, the public institutions and the institutions have each implemented international cooperation projects, and this convention will be an opportunity to show their solidarity in this with Corona period. And we have discovered the social value that we have to cooperate in order to overcome the crisis. 140 Korean institutions and agencies are participating in this convention. And as one team, as Team Korea, we will be gaining a lot of insight and learn from many implications. On and offline hybrid events were planned ahead, but because of COVID-19, the third wave upon us, this is a very critical moment. And so we could not have this event face to face, but we have still the online platform, and I'm sure many people are watching. Up until now, Korea has gained a lot of soft power based on its hardware capabilities, and without such learning and knowledge, we wouldn't have been able to have such an online event. It would have been nicer if people could gather together and meet face to face at the convention, but that cannot be the case this year. We're dealing with the topic of K-quarantine and healthcare in this very session. We are experiencing the third wave of COVID-19. Up until now, Korea has been able to weather the COVID-19 pandemic with the K-quarantine capability, and we're known for that worldwide. 3T, testing, tracking, treatment. The process of 3T has been abided by, and this was linked to our quarantine and prevention measures in everyday life. This was thanks to the people's participation and voluntary compliance. Korea's soft power began to gain recognition, and cultural, educational, science, and technological areas, we are able to respond very well in the welfare sector, and I think we're gaining recognition worldwide. We need to re-evaluate K-quarantine and visit Korea New Deal and to become one of the active leaders in the global arena. We need to rethink Korea's role, and I hope this will be an opportunity to discuss relevant topics. Along with quarantine, there are many aspects to health and welfare related industries and public health, social insurance systems. We need to visit these issues and take a leap forward. With that, I'd like to close. Thank you very much.
그러면은
And now, from now on, it is time to listen to the congratulatory remarks. So, on behalf of the Minister Park, Director Go is going to read the minister's speech.
안녕하십니까.
Good afternoon. Hello, I am Go Tae-kyung from Ministry of Health and Welfare. I welcome you all to the Global Korea Convention 2020. I hope today's convention will be a forum for countries to share their wisdom, particularly for Korea to share its wisdom, experiences, and insight to achieve sustainability, peace, and prosperity for the global community. Minister Park was originally scheduled to be present to deliver his remarks, but as you are well aware, the COVID-19 situation is quite serious now. So there was an emergency cabinet meeting he needed to attend. So I am going to read his remarks instead. Good afternoon. This is Minister Park from Ministry of Health and Welfare. I'd like to thank Ki-hee-sa and Director Jo of Ki-hee-sa for putting together today's convention. The COVID-19 is leaving an important mark of our time. People are fighting against this infectious disease, and I'd like to express my sincere consolation for everyone who is struggling with this disease. And also, I'd like to express my heartfelt gratitude and respect to all healthcare workers and also professionals at the health organizations as well. COVID-19 has turned upside down our life. Overall, over 60 million confirmed cases are reported around the world, and 1.4 million people lost their lives to this disease. We are virtually in war against this infectious disease, and no one can be a winner. A virus does not know race, region, or national border, so it requires coalition and cooperation among countries. We need to share information, and we need to work together. And that is actually the power that the humanity can muster up against virus. This coalition is the biggest strength that the humanity can have. Korea was doing well in terms of controlling this disease, but still Korea is struggling with COVID-19. But still, thanks to the close cooperation with the international community, Korea has been able to contain the disease relatively well. And Korea actively researched about the characteristics of COVID-19, which led to the successful development of a testing kit. And also, we restricted incoming international travelers entry into Korea. Also, we implemented social distancing measures and other quarantine measures as well. The K quarantine incorporates transparency, democracy, and also it incorporates scientific innovations as well. So we are being flexible and creative in addressing the COVID-19 spread, including WHO and other international organizations and international media, have praised Korea's quarantine measures positively so far. And also, we are actively sharing our knowledge and experiences with the other countries as well. Many countries are actually inquiring us about how to contain and mitigate this disease. And we are only happy to work with the international community to fight this disease. And also WHO and G20, ASEAN, and also consulting body among China, Korea, and Japan. In these international avenues, Korea has been active in sharing what we know and also raising the awareness of this disease. We embrace inclusive multipolarism in terms of minimizing the impact from COVID-19. So we are going to continue to actively cooperate with the international community and international institutions as well. We'd like to share our experiences with countries less well positioned to deal with this challenge compared to Korea. We need to fight this together. And also in terms of vaccine development and vaccine distribution, we will pursue equity as well. We'd like to pursue international cooperation for each country's equitable access to vaccines. And also we would like to participate in many international avenues so that not just developed countries, but also developing countries and much less developed countries can also benefit from vaccines as well. Korea has been very actively participating in WHO and other international avenue. And we'd like to cooperate proactively in terms of revising any relevant international standards or guidelines. COVID-19 is leaving a big impact on our life, but at the same time, we are receiving positive news about vaccine development. So if the global community put our wisdom together and work together, we can overcome this crisis together. Thank you very much.
대단히 감사합니다.
Thank you very much. And now I would like to invite the two speakers to present. As the first speaker, we have the researcher Kim Nam-sun from Kihasa, and the topic is response to COVID-19 in 6 European countries and comparative analysis of health and medical system. Please use 18 minutes of your time. Thank you.
한국보건사연구원의 김남수입니다. 저는 이제
Hello, as introduced, I am Kim Nam-sun, and my topic is going to be COVID-19 responses and healthcare in 6 European countries. So let me begin my presentation.
예. 그 코로나
So COVID-19, initially Korea and other Asian countries and New Zealand, we kept a very small number of patients and death as well. So we were doing well. But at the early stage, Europe saw rapid increase in confirmed cases and death. So many people wondered whether Europe's response to COVID-19 was flawed or not. So this is the data from 6 European countries: France, Italy, Germany, UK, Sweden, and Finland. You can see an increase of the cumulative confirmed cases as well. This is fatality, which is also high. Relatively speaking, Germany and Finland show low mortality rate, but that is not the case for the other 4 European countries on the graph. So given this European situation, the UK and France, they began questioning why they are not responding well to the COVID-19 crisis. So here, the commentators say that this is similar to the division between the right and the left during the World War II, which led to some defeats during the war. So some commentators drew analogy between the World War II situation and the current COVID-19 situation. So then the next question was then why did Europe experience such a division and still inadequate response, despite the fact that Europe has really leading scientists and medical professionals by any global standard. And this is Sweden as well. So Sweden's response was quite controversial. So Sweden's response was very different from other countries' measures. So was Sweden's response failure or not? The jury is still out on this. But personally, I think that in Sweden, Sweden also has their own version of CDC, and the Sweden's CDC director said that if we can go back in time, we probably would have taken stronger measures. And also, they didn't do quite so well in terms of taking care of the elderly. So I think that's the Swedish government assessment of its own response so far. So this is the death numbers in Sweden, as you can see here. So it's kind of hard to say that Sweden's unusual response was success compared to other countries, but still, Europe has a very highly developed, highly advanced healthcare system. So in terms of testing cases and gathering data and publishing the data, it's being done very well. So and also in terms of the healthcare professionals' infection rate, the number itself might look high, but that's also because European countries are very strict and are doing well in terms of getting the data and getting medical professionals tested. So I cannot say that we cannot say that the European situation is better, but their measures against COVID-19 are not necessarily a complete failure. So then, these advanced countries in Europe, why have they not been able to respond better? They could have responded better. Then why that is not the case? Actually, coronavirus is similar to SARS and MERS. SARS and MERS have occurred in about every 10 or 15 years as a kind of cycle. Asia experienced the SARS and MERS a lot in recent cases, but that was not the European experience. Even if MERS, for example, occurred in Europe, there were only a handful of cases. So Europe actually didn't experience a wave of infectious disease in recent history. So they had a preconception that the COVID-19 is kind of Asia-specific disease. That's kind of my personal assessment. And also the new influenza experience. So it took place in 2009, 2010. At that time in Korea, we had the experience of procuring treatments such as Tamiflu and also vaccines as well. But in Europe, they had a financial crisis in 07 and 08, starting from the subprime mortgage crisis, as you remember. So after that, WHO, even though WHO set out a guideline to build a stockpile of treatment for new influenza, for example, Tamiflu, but European countries couldn't do that, didn't have enough stockpile. And so the Cochrane Group, according to Cochrane Group's review, they also said that Tamiflu effectiveness is questionable compared to its adverse effects. So back then, regarding Tamiflu, European countries were thinking, well, Tamiflu is a kind of controversial treatment, and we are now dealing with financial crisis in our hands, so we don't have much time, much money to buy Tamiflu. So that was the situation in Europe years ago. So, and also overall in Europe, the healthcare budget was cut back, and some healthcare centers were closed down as well, which led to an overall reduction in the number of hospital beds. So the healthcare infrastructure kind of weakened as well overall in Europe after the financial crisis. And next factor is China factor or globalization. So coronavirus took place, first appeared in Asia, but still we are now living in a globalized world. So for example, Italy has some commercial ties with Asian countries, including China. And also we have goods being transported across border. So this globalization had an impact on the spread of COVID-19, of course. Let me skip this slide and let me move on to the healthcare insurance, healthcare system and insurance as well. So you can see that most of the countries, European countries, have a national insurance system. So, and also, as you can see here, so Sweden, compared to the GDP, healthcare cost is high, or rather, healthcare budget is high in Sweden. Now let's take a closer look at the European response to the COVID-19. So it's been about a year now. So which one should be a priority, containment or mitigation? Containment is more appropriate at the early stage. So basically it means to prevent the disease from spreading further into other regions. But once the disease is spread into different regions, then the priority should be on mitigation. So containment is more proactive and aggressive, and mitigation is kind of a responsive measures. But that does mean that there is a clear-cut boundary between containment and mitigation. And if you look at the responses taken by most European countries, they viewed it as already widespread disease that was spread into local communities. So they were less aggressive about implementing rapid testing, for example. And here's a quote from a Finnish official here. So in the case of the Finland, they priority was to lower the curve, but the COVID-19 got spread much faster than expected. So if you look at the testing trend here or testing data here, so this doesn't mean that so this shows that eventually European countries also got hold of a lot of testing kits, and they ended up conducting a lot of tests as well. For example, Germany, Norway, and New Zealand as well. Well, although New Zealand is not a European country. But so, in a nutshell, as of now, European countries also conducted a large number of tests as well. So here, Germany was the most aggressive and proactive in terms of implementing the test. So even had a broad testing base, targeting broad segment of population. And now this is the case of France. The problem is, the problem was most acute, I'd say, in February, March, and April in Europe. So there was some confusion in terms of the response strategy, and I'd like to urge you to read this slide at your leisure. And so these are strategies that France took at the early stage back in spring. It was controversial within France itself. So all in all, there was some discrepancies country by country, but overall in European countries, they didn't have a high level of awareness about COVID-19, and also they was not too much concerned about the COVID-19 when it was taking place in Asia, and also the level of their preparedness was not that high in terms of the number of test kits that they had originally or the treatments that they had in stockpile, for example. And also in Asia, for example, in Korea, we experienced the MERS outbreak as well. So because of that, we already had a know-how to build IT infrastructure to contain and mitigate an infectious disease. But Europe didn't have such experience, so they didn't have this kind of infrastructure as well. So, for example, even though in European countries, some countries try to use IT technology for contact tracing, but that was not mandatory, so it had only limited impact. And another issue was asymptomatic cases as well, or mild cases as well. So for these cases, patients are advised to isolate themselves at home usually. That's the European response. But in Korea, those asymptomatic or mild cases, they are isolated in a separate facility where medical professionals can observe their status, their health status. And also, this is the Italian case. And even within a country, depending on each province's strategy, the response effectiveness was very different. For example, in terms of the Veneto area or vis-a-vis a Lombardy area, Veneto area had a much more aggressive and proactive response. So they kept the mortality rate low despite the prevalence rate was high. But unfortunately, the Lombardy area was not like that. So in certain cases, there were a lot of rapid increase in terms of new patients, and the hospital beds were exhausted very quickly. So social lockdown was in place, and also later on, soft lockdown was in place even in Sweden as well. So the social distancing was monitored by a research center in the UK, and they gathered some indicators. So this is what they gathered, the government stringency index. So if you can see here, France, Germany, UK, Italy, all these countries that had a very strict policy. Whereas Sweden, they didn't go for a strict policy at the beginning. And also wearing a mask. In Korea, people are not resistant to wearing a mask, culturally speaking, but that is not the case in Europe. But over time, it was advised and even mandated to wear a mask in Europe as well. And according to this study, we can also take a lesson from the European cases as well. So, for example, in Germany, for Robert Koch Institute is the Germany's federal government's central institution for public health protection, and also public hospital beds number twice or even triple times more than Korea. I'm talking about public hospital. So in certain cases in Europe, there are many more hospital beds available in public hospital sector. So that's what Europe is doing better than Korea. And also here, the intensive care unit as well. Germany has a lot of ICU. Why is that so? I think it's because Germany had a really severe experiences in the past, for example, 2 world wars and also economic depression as well. So because of such history, I think Germany has an ICU, a lot of ICU. So, and that actually paid off during this pandemic crisis. What about the UK and Finland? They tried very much proactively to secure enough hospital beds for COVID-19 patients. For example, in the UK, well, both UK and Finland, they secured over 10,000 hospital beds. And also, the hospitals are managed very much efficiently. And in the case of Germany, they have actually an ICU patient registration system. So you can monitor and check where there is an available ICU bed. And also, if you look at the medical staff support, in order to prevent medical professionals or frontrunners from getting exhausted too soon, they allowed medical school students to go in and help out. And also in Germany as well, they are now trying to increase the number of doctors as well. And in France, they're now trying to increase the salary for doctors as well. So now they're setting aside a government budget for that. So many nurses and doctors actually used to protest for their low salary. Now the French government is trying to increase their salary. Now, R&D infrastructure. Korea was did well in terms of dealing with the disease, but in terms of data gathering and studying the disease, I think European countries definitely have an edge. So this is my conclusion. So in the globalized world, a virus does not know a national border either. And an infectious disease outbreak can have a severe cost in terms of security, economy, etc. So we need to have a resilient and a sustainable healthcare system. And also chronic illness. Chronic illness definitely needs to be highly prioritized because of the aging population around the world. But now, on top of that, we need to think about infectious disease as well. So chronic illness and infectious disease, they both need to take top priority in public healthcare system. And European countries, even though they struggled a lot initially, but over time, their response became much better. And also in terms of the number of hospital beds, and also in terms of injecting a massive government budget, European countries became more proactive in dealing with COVID-19. So this is the summary of my presentation. So initially, due to the lack of awareness about COVID-19, Europe did not respond in a more agile manner, and yet the public health infrastructure that was built helped European countries ultimately to deal with COVID-19 better. And also, depending on the country's economic level and social cultural level, there was discrepancy country by country in terms of public healthcare system, the number of hospital beds, and the medical professional capacity as well. And overall, Europe does very well in terms of investing in hospital beds and human resources and data system and research infrastructure as well. And that is something Korea needs to learn from Europe. Thank you very much.
한 우리나라에 주는
There were a few implications for Korea.
실패한 것
So initially, Europe might appear to have failed, but Europe also showed a lot of strengths as well over time. So definitely, there's something Korea can learn from Europe as well. For example, the number of beds in the public hospitals and also public healthcare professionals as well. So we need to secure these resources in Korea as well. That was lesson one, I would say. And the second, a lot of research data. European countries are doing very well in terms of gathering research data, which can bode very well for future research endeavors. And Korea is, of course, doing some research as well. And third, and also, the European countries are even raising the salary for healthcare workers and professionals. And also, the overall public healthcare management system was in place before the outbreak of the pandemic, which paid off. And also, there were some issues in Europe as well. For example, contact tracing. So contact tracing was a controversy in France. And if we are going to trace the contacts, then how much are we going to trace it? I think that's still an ongoing debate on it. So actually, Ms. Kim made a great contribution to drafting a white paper on this topic. And so the white paper is now in progress, and Ms. Kim is a big contributor to that.
우리 의과 서울
And now I'd like to invite the second speaker, Dr. Yoon Kim from Seoul National University Hospital. He's going to talk about K-quarantine must evolve. Please keep your talk to 20 minutes. Thank you. Good afternoon. I am Kim Yoon from Seoul National University Hospital, the medical school. I'm going to talk about K-quarantine. We are now faced with the third wave of COVID-19. How should we evolve K-quarantine so that we can have success in this third wave as we have succeeded in overcoming the first and second waves? The level has gone up to 2.5. This is the Myeongdong neighborhood. It is quite empty, the streets. And so social distancing was a must. The scale has risen much higher than the second wave, and we see signs of the third wave. And at this juncture, we should look back on what we have done and what were some of the problems in our past measures and talk about what we should do next. For quarantine, looking at the aim, there is social distancing and practicing personal quarantine in daily life to reduce the number of infections. And there needs to be testing and tracking so that there won't be the nth infection. And as for the confirmed cases, they should be treated according to the level and severity scores. And after they're fully treated, their case fatality should be reduced. Social distancing and testing and contact tracing and treating the patients. This is the core of COVID-19 quarantine. And so how have we done this so far, and what were some of the problems, and how should we do this? Let's first look at prevention and control. Up until now, this graph is showing the number of patients per population of 1 million. Korea is at the very bottom, and so are the other Asian countries. What this shows is that up until now, K-quarantine has been successful. If we look at the US and other European nations, we're able to reduce the number of confirmed cases. But what were we sacrificing? How could we reduce the number of confirmed cases? I would like to show you this graph. On top is Korea and the bottom shows Japan. Since the spring season, it shows the increase of the confirmed cases, and as was mentioned by Ms. Namsoon Kim, there's the Oxford Stringency Index. How strong and how stringent were the social distancing measures? As you can see, in Korea, the number of patients is low, and even then, there were stringent social distancing policies. In Japan, compared to the number of patients, the stringency was low and social distancing was much more flexible. And so Korea was very stringent. Even when there were few cases, the high level of stringent social distancing policies were in place. And is this the right way to go about it? In the US and Europe, according to this system, if there's one patient per 100,000, then that is the safest environment. And if we apply this, it is 500 cases. And when there's explosive growth in confirmed cases, it would mean 13,000 daily new cases. And so we still have a way to go until we can say that there's an explosive growth in the confirmed cases. And along with the stringent measures for social distancing, one of the other reasons we had to do this was because we could not have access to enough hospital beds. During the second wave in the summer season, there were patients and this shows the parallel social distancing measures. And what you need to look at is the situation after September 12th. It peaked for 2 weeks and the number of patients went down. And the number of patients was 135 patients per week. It was stable. If we had enough beds, then at this time, the social distancing level could have gone down from not 2, or it could have been down to just level 1. It was because the government could not secure enough beds, and so social distancing was enforced, and it was the non-regular workers and the small merchants who suffered from the stringent social distancing policies. And this shows the effect of social distancing. Apple is showing the mobility data. In Korea, since January, the amount of movement, mobility has gone down. It went down one notch in August, and now in the third wave, we have very little mobility. And in the US and the European countries, the government, even if it enforces stringent social distancing policies, the people still move around. The effect of quarantine is guaranteed only by the people's voluntary participation. The government has to secure enough beds and has to secure enough medical resources and staff, and then ask the people to abide by the social distancing policies. But the government has been negligent on getting the resources, but is just forcing the people to abide by the social distancing policies. So it can be evaluated that the government is passing the responsibility on to the people. And now let's look at treatment. What this shows is as of May end, Korea is compared to the other countries for simple fatality and age-adjusted fatality on the right-hand side. The reason why we have to look at the fatality adjusted by age is the fatality is higher in the elderly and lower in the younger generation. So we have to make the age adjustment. And after the age adjustment, we see that the number goes up in Korea and the number goes down in Europe. 3.9 in Spain, and if we compare the 3.3 in Korea, there is not much of a difference. And we can still confirm this in the recent data. On the x-axis shows the COVID-19 patients, and the y-axis shows the number of deaths, and the shaded area shows the fatality rate. And Korea is right about here. It's in the middle of 1% and 2%. And as you can see from the graph, the Korean fatality rate, even if we consider the number of confirmed cases, it is not that low still. And the reason is as follows. The COVID-19 patients were treated 80% of the time in the public hospitals, and only 20% were treated in the private hospitals. And so the role of the public hospitals stood out, and it was a rediscovery of the value of the public hospitals. But the public hospitals in the local areas, the veteran hospitals, the military hospitals, they are very small scale hospitals and they don't have enough ICUs and enough beds. Depending on the severity of the patients, where were they treated? For the critical and severe cases, they should have been treated in the ICU, but 55% of the patients could not have access to ICU and were treated in the general wards. And for moderate cases, even if they're treated in the regular hospitals, they should be treated in large hospitals with 300 beds, but 30% of them were treated in smaller hospitals. And so the smaller local hospitals in the provincial regions did not have ICUs and could not treat the severe patients, and thus the higher fatality rate. And so if we look at the Daegu situation, there was a mass infection due to Shincheonji religious group. Were there no beds? The mayor of Daegu said, we don't have enough beds in Daegu, so please treat the Daegu patients in other cities. And there were 17 people who waited for hospitalization but died at home. But at the time, in Daegu, there were general hospitals and university hospitals. And if we look at the bed utilization, looking at the first tier general hospitals, the blue shows the bed utilization during the normal times and the ICU bed utilization. And during the February and March, the ICUs one half of the beds were empty in the first tier general hospitals. It wasn't that the beds were not available. They were there, they were empty, but there was no system for the government to utilize and mobilize these empty beds. And the current and such situation has not changed, and this continues to this day, not much difference. And so I've said this, the level of treatment is not that low, it's around average, and the reason is there was no system to mobilize the beds. This could be the government's responsibility. And so there were patients who could not be hospitalized and they met death. And the number of patients could be higher who could not be hospitalized and died. And this is tragic. And this could happen again in the coming months. So what should we do? First, we have to have enough medical resources at the city level and at the county level. We have to form a new organization, and we have to secure enough human resources. And so we need to have speedy epidemiological investigation. And so there should be an additional 1,800 medical staff, but actually only 500 people were added to the team, and the decision was made too late. And so the decision came, but the city level and county level people still do not have up-to-date and speedy epidemiological investigation. And this shows the duration from the first symptoms to diagnosis. The longer the delay, this patient has a higher likelihood of infecting others, and this could lead to a mass infection. In June, it took only 4.2 days, but it went up to 7.6 days. And this is the duration from the first infection to the last infection in a group. If there is precise epidemiological investigation, if the people who came into contact were separated, there should be no infected cases after 14 days. If there were additional infections, that means the epidemiological investigation had some errors, and you could not isolate the suspect cases. And so there were 1/3 of the infections that were due to failure of epidemiological investigations. It used to be only 17%. And so these are the actual cases. It took 30 days, 20 days, 16 days from the first symptoms to diagnosis and the duration of infection. After 14 days, the nth infection had taken place as of December 4th. This shows how long the duration of the infection was. The initial epidemiological investigation had failed because 14 days have lapsed, and this shows that there is a correlation. And the second recommendation was to secure enough beds and enough staff. Through social distancing, we need to reduce the number of infected persons, but at the same time, we need to have higher medical capability so that even if we have a lot more patients come on, we have the skills and the resources to treat them properly. In the US and Europe, this is showing the classification of the patients depending on the number of infected cases. If there are 500 daily infected cases, and if they're hospitalized for 14 days, and if 5% of the population is severe, then we would need 350 beds. Even if we have 500 people who are infected every day, if we have 300 beds in ICUs, we wouldn't need to escalate social distancing due to shortage of beds and because patients cannot get to hospitals. Except for the pediatric patients, we have about 6,000 available beds, and 40% of them are allocated for the emergency patients. And in the ICU, we have 3,400 beds in the ICU that are available. And so if we have 500 daily new cases, we don't have to worry about the medical system collapsing. 360 beds, 10% could not be secured by the government, and the government is having the people worry about not having enough beds. We have to classify the patients, we have to calculate the number of beds needed, and we have to look at the distribution of the daily new cases. And so we have to have different scenarios of 30,000 infected cases and 100,000 infected cases. And we have to have a control tower and mobilize the resources. And we have to secure the beds at a discount at each county level and provide the compensation accordingly. So the role of the control tower is still with the Ministry of Health and Welfare, and there are designated infectious disease hospitals, but they are not doing much. And the hospitals are not designated to treat the moderate cases. And for respiratory clinics, the plan is just on the drawing board and nothing has been put into action. And so if we move according to the scenarios of the number of infected patients, in the first phase, we have to mobilize the state designated hospital beds, and second stage is 40% of the regular hospital beds, and phase 3 would be an escalation. And so depending on the number of patients, this shows the number of beds that can be secured. And we're now around 600 daily new cases, and 40% of the isolated hospitals, then we can have access to about 560 beds, and we wouldn't have a problem if the government had accepted our recommendation. So that was the bed. And for the medical staff, we need to have 1,700 more medical staff in the general wards. You need to segregate the wards, and you have to have more nursing resources, and we have to separate the ER into two different spaces so that suspect cases can come into the ER, and there needs to be control measures for the nursing homes. 40% of the deaths were from the nursing hospitals and nursing homes. And so we did recommend the government to take care of the control policies in the nursing homes. Only after 1 week has passed, we see the first symptoms, and in a week we see dozens of infected cases come out from the same nursing homes. And if we look at the patterns, these are the high-risk facilities, mid-risk facilities, and low-risk facilities. And as you can see, for 10,000 people, we see that there are a lot more infections coming from the low-risk facilities, and they're the psychiatric hospitals and nursing hospitals and nursing homes. And as of December, about 18% of the mass infection is coming from these facilities. Other than testing, the government should provide the appropriate fees, staff these facilities, and put in place control measures, and check the temperature of the residents of the nursing homes every day. Then they wouldn't have dozens of infected cases come out in a week. And one last thing I would like to say is this graph you're looking at is showing the situation in the Gyeonggi province. This shows the infected cases except for the asymptomatic patients. 7 days after the control measures are in place, you see the curve flattening, and then you see the graph going down. And so this shows that the social distancing is effective, but the government does not accept this because they don't draw such a graph. And if you include the asymptomatic patients, you see a similar pattern. And why is the number of patients increasing? Social distancing may be effective, but sometimes the measures are not abided by, epidemiological investigation is not done properly, and mass infection is not controlled, and that's why this is increasing the number of patients. The government should not depend too much on social distancing, place the responsibility of quarantine not only on the people, secure enough beds, secure enough staff, secure enough control policies in the high-risk facilities, and a daily infection case of 500 is too low. Increase the capability of the medical treatment first so that there is a balance of daily quarantine and government measures. Then we can have quality of life. Thank you very much. Thank you for the explanation, and I do not need to add comments or summarize. Having listened to the two presentations, I would like to ask the two speakers and the three discussants up to the stage.
예, 그
Okay, so to start off the panel discussion, we need to finish by 3:30, so we have about 30 minutes sharp. So I'd like to ask our discussants and also our presenters as well. Please limit your remarks to 7 minutes. Designated discussants, please keep your comment within 7 minutes. And you have a list of the names of the discussants on the convention brochure. So let's start with Mr. Yoon Kang-jae from Kihasa. So please finish within 7 minutes. Set a great example. Thank you. Hello, as introduced, I'm from Kihasa. My name is Kang Jae-yoon. Thank you very much for all your great presentations. And Professor Kim gave us a lot of feedback about Korea's response. So I think that was a really great feedback. And we also listened to the European response as well. So I believe that the two presentations will lay the foundation for better response measures in Korea. Today's convention is not about policy advising, so I'd like to just freely share my thoughts. So Professor Kim gave us 4 main points, and I agree with most of the points. And it's a shame that we don't have more time to discuss his presentation.
하는 의미에서
And so, to flesh out his ideas, I'd like to say a few words. As for securing more staff, I do agree in principle. For example, epidemiological investigators, we have many, but quantitative growth is one matter. How should they train? How should they be trained, and how can we have quality investigators? That is a homework to be solved. And I think the government needs to put some thought into this. And maybe in the interest of time, there was mention of public health centers in the presentation material. Well, this is part of the medical service delivery system, and I think we should pay more attention to what role the public health centers should play. And you talked about 1,800 people, and there are 2,500 public health centers, so we would be having 7 more additional staff in each public health centers. And so what should the org chart look like for each public health centers? We saw this in the first wave, and when there was mass infection, everyone was assigned to the selective screening centers, and other care services were put to a halt. So how should the public health centers respond in a serious pandemic situation? I think we need to give it some thought. And for the system mobilizing the human resources and the beds, as you're well aware, well, the word mobilize and secure came up, but we have more private hospitals than public hospitals, and how to mobilize the private resources would be difficult. There was mention of respiratory clinics. If it's a first tier clinic, it's difficult to segregate into different quarters. And so how should we have the COVID-19 proof respiratory clinics? And so I think maybe with the limited resources, we're able to operate the resources. But other than the operation aspect, maybe as Professor Kim said, we should have more quantity, and I think investment needs to be made. And you talked about the living treatment centers. For mild cases, they're in the living treatment centers where they self-isolate them at home. I think primary medical care is not playing its due role. So living treatment centers and the self-isolation and the primary clinics should be connected, and they should be supplied with the ICT technology. And the mild cases are treated usually in their neighborhood, and there should be a follow-up measure. So maybe the primary healthcare facilities can be dedicated to treating the mild cases. And as for the vulnerable facilities, not only the nursing homes, we do see a lot of vulnerabilities, not just health and welfare. And as was mentioned by the professor, economically vulnerable non-regular workers, platform workers, are hard hit. And because their income is unstable, the social safety net should come into play, but it is not targeting the right people. And so sickness benefits in the European countries helped, I think. And so yes, I do agree that K quarantine should evolve, but not only in terms of the medical aspect, but we need to evolve in terms of the social safety net. And that is talking about the human New Deal. And so we need some growth in other industries to enforce the social safety net. And we are compensating the healthcare sector, but we do need to see some progress in the social safety net to have balanced K quarantine. Thank you.
And next, from Korea Institute of Healthcare and Public Health, Dr. Kim. Hello, as introduced, I am Soo-kyung Kim. I mostly analyze patient safety and also medical facility or hospital assessment as well. So I participated in Dr. Kim's study into European responses to COVID-19. I think that's why I am here today. So decentralization was a big theme in European countries. But the European system also revealed to have some weaknesses in terms of responding to COVID-19 at the initial stage. So I think Dr. Kim's study was very timely, and she pointed out what could be better in terms of the European response. She looked at European response to COVID-19 at the regional level and at each country's level as well. She also highlighted the differences among countries as well. And also, she put forward some ideas as to how to respond to COVID-19, including international cooperation. And containment or quarantine and treatment, and all these measures need to take place with great coordination between the central command tower and regional medical facilities. That's how I read her study. And also, a country's response to COVID-19 incorporates the society's culture and overall awareness about the disease. So, for example, mesh bar screening and contact tracing and wearing a mask. So mesh bar screening was questioned a lot in certain European countries, for example, in Sweden. And IT-based contact tracing, that was controversial, particularly in France, because of privacy infringement issues. So that's a difference between European countries and Korea. In terms of the acceptance of using IT technology to trace contacts, in Korea, we didn't have much resistance from the public, but there was resistance in Europe. So even among experts in Europe, they advised paper record first. And so in terms of the perception gap or cultural gap, aside from these cultural issues, other physical, practical, logistical issues, for example, procuring testing kit and other necessary equipment, that was an important factor. For example, Finland, they rely on import for these equipments and materials. So they had a lot of stockpile in advance, so that helped. And also, in Italy and the UK, things got more severe compared to a country such as Germany. So Germany, they procured more resources in advance, which paid off really in this pandemic crisis. And I think Professor Kim also touched upon securing enough materials and equipment for this. In Europe, many people are talking about COVID-19 fatigue. So, for example, there is an increase in the portion of COVID-19 patients in the ICU part. So, the medical professionals are getting tired. They're experiencing COVID-19 fatigue. And there may be other kind of infectious disease even after we overcome COVID-19. So so Europe seems to take this as an opportunity to prepare and to improve upon their response to infectious disease. But we also have great news. For example, vaccine developments, and the vaccines are being approved in Europe as well. Vaccine is a key factor for us to go back to our normal life. Now in the UK, a vaccine usage is approved, and now they already are confirming which demographic segment will be prioritized in terms of getting vaccinated. And they're also having discussion about building necessary facility. And for treatment options as well, some options are now in clinical stage 1 to 3. So if the approval is put on fast track, then it can speed up the treatment availability as well. But it cannot be too expensive. It should be still affordable. So I think necessary data is being compiled as well. We are also involved in HD Society and in other international forum, and we are having active discussion on these as well. And Professor Kim gave us a very detailed talks about this. For example, how to mobilize hospital beds. Well, I think we need to provide monetary compensation, but do we have enough budget for that? So that will be my concern. Most importantly, in my view, we need to build not just the hardware system, but also software as well. Software, I mean how to operate the hardware once we have them in place. For example, various guidelines. And also in terms of the quality of healthcare services, a lot of international gatherings are now talking about the safety concerns for medical professionals at the front line. So actually, the front runner medical professionals, their safety is a big concern because they're the one who deals with patients on the front line. And lastly, Korea did well initially in containing COVID-19 because we had a great IT technology, and also we had a isolation center for patients, and also we even isolated mild cases as well separately. So that was a great precautionary measure, I believe. And we also prepared, we also need to further fine tune our guidelines for mild cases and other cases as well. And also patient-reported outcome or patient-reported indicators. So these data can be utilized as a useful indicator. So, and also these kind of data can be utilized for approvals for health authorities like FDA. And also personal decision making needs to be supported by relevant data and by ICT. So we need, Korea did very well in terms of using IT and also the public participation in containing and mitigating an infectious disease is very important. So to do that, we need public cooperation as well.
지적된 쭉 해주신 게 한.
Yes, you pointed out 8 issues. Dr. Namsoon Kim, please address the points raised by Dr. Soo-kyung Kim. And the last discussant is a very busy professor. We have Professor Ji-hyuk Park from Dongguk University Medical School, and he wears many hats. And so I think he has a lot of first-hand experience. And so could you add more flavor to our discussion? Yes, I am Ji-hyuk Park. I was the epidemiological investigator at Korea Disease Center at KCDC, and I have also worked in many hospitals, and I was in the front line responding to the pandemic. If I had more time, I would have talked more about the merits, but in the interest of time, I will skip the advantages. The impression that I got was we're doing well in the short term, but I think it is time that we transition to a long-term response. Back in 2015, when we had the MERS outbreak, our response was a failure, and after that, there were a lot of changes. there was a lot of learning. So, in the response to COVID-19, we were better compared to the other countries. And as Dr. Kim Yoon mentioned, the recommendations have not been accepted. I hope that the third wave will provide the government with the opportunity to accept the recommendations. The core of the quarantine measures, I think, is the public health centers. When we look at the cases, it is mostly at the public health center level that is at the front line. So training the professionals at public health centers is very important. And so the provincial offices, they dispatch people to train people at the public health centers. But what is challenging is the person who is responsible for the infectious disease. Well, nobody wants that job because it's difficult, you're not paid well. And to be frank, in July, when there was appointment of public servants, there was a lot of concern. The people just rotate. The people are tired, they burn out, and so uh, there's no learning curve, and there is not enough time for them to accumulate expertise. And there was a similar warning made about the fatigue issue. And so there is fatigue and burnout, but there is no response measure to make up for the loss of professionals. And after the infectious disease is done, what will these professionals do? Then you can say the same thing about the firefighters. If there's no fire, will they be sitting idle? So people think that if there are too many people in the public health centers, then they won't be doing much. But I think they're the ones who can come up with the basic data. Why don't we have the research data coming from the COVID-19? With just the few resources that we have in the public health centers, we cannot get the basic data. But if we staff more people at the public health centers, then we can have more precise basic data about the cases. And what is frustrating in the public health centers is they don't know how to form the emergency organization, and there's no training. So it should be the head of the public health centers who designs the organization in emergency situations, but he's not resident at the center. He goes out somewhere to make a report. Let's say the commissioner of the Korea Disease Control Agency is out there reporting to the president, and that's what's happening at the public health centers. If there's an emergency, the head of the center should be making the decision, but he's absent because he's somewhere making a report. So I think some of these processes should be improved. And as for the status and the statutory roles that the public health centers can play, when I visited one region, I mentioned that you should ask for public officials in other county offices and city offices because you don't have enough resources to do the work at the public health center. But according to the law, the head of the public health center does not have the authority to ask for more resources. Public health centers are very unique in Korea. We don't have similar organizations in other countries, and we are proud of having such an organization, but there are so many limitations. And there's a lot of work to be done. The people who are dedicated for epidemiological investigation has risen from 30 to 300, but the person in charge has not changed. We have a model in Korea. in order to secure beds or secure enough staff, we have this budget shortage. And I think if there is a need, we could get the budget support from the central agency. In order to have a speedy response, I think there should be some budget support. And as for the personal quarantine measures, we have very good facial masks. In February and March, used we're using dental masks now. And so what quality masks should we be using? We could get the basic data from the public health centers, but we cannot ask them for the data. Similar things are being done in Germany, so we should dedicate resources for research. Otherwise, we cannot have data. And masks should be supported, some people say. Yes, it could be supported as a form of disaster relief. You could provide people with subsidies to purchase quality masks instead of just asking people to wear masks. And I'm surprised watching the news. Some programs show people not wearing the masks properly, and this is giving out a wrong message to the people. And so the media should be precise about the mask protocol. And as for the vaccines, if the vaccine is distributed, there could be an increase in the confirmed cases because people will be wearing masks less. And so the message of wearing the right mask properly should be disseminated. Otherwise, even with the vaccines, I think there could be an increase in the number of infected cases. Thank you very much.
아주 생생한
So we were able to listen to a really vivid first-hand experience from Professor Park. We've listened to from all designated discussants. Now it is our speaker's turn to respond. We will start with Professor Kim, followed by Ms. Kim.
Thank you for your helpful comments. I do agree with most of the comments, and I just have two things that I want to share with you. One is about the beds, and two is about the epidemiological investigators centered around the public health centers. It's not the shortage of beds that is a problem. There are beds available. The government cannot effectively mobilize the beds. The hospitals do not want to accept the COVID-19 patients, and instead they treat the lucrative patients, and they're not releasing their beds. What should the government do? For the first year, general hospitals and national university hospitals, they should release 10% of their available beds. And if the hospitals do not comply, they should be delisted from the top-tier general hospitals. 1.5 trillion won is paid more to these top-tier general hospitals, even if it's for treating the same disease. They want to hold on to their beds, and they're being selfish, and we cannot provide them with 1.5 trillion won more. If the government cannot exercise this, then it means that the government is powerless to defend the people's health rights. And as for the public health centers, yes, their roles should be enforced. And as was mentioned by Professor Park, Yes, the people working at the public health centers should be able to collect data so that it can be used in actual disease prevention and control. And so, if you were to draw the curve from the first symptom to the first infection, we wouldn't have had to escalate the social distancing. We could have found other factors, and the government could have come up with other measures. And if you just looked at the number of infected cases and if you escalate the social distancing measures, then the government is working off of no data, and it shows that there are less resources than needed. Thank you, Dr. Kim Namsu.
상황을
Yes, I reviewed the European situation. So if I can sum it up again, as Dr. Kim mentioned, so I think it boils down to the enough procurement of hospital beds and data, R&D, and medical professionals. So although they were not highly prepared initially, which led to a rapid increase of confirmed cases initially, but still they're doing well. So that's what I want to focus on. So the number of ICU beds. For that, the European government definitely secured enough number of ICU beds. They also have a public hospital system where a lot of ICU beds are available for a situation like this. And in terms of human resources as well, of course, there's a limitation in Europe as well. But Europe took a lot of care to manage human resources. So, for example, in Germany, they allowed medical students to come out and help out in terms of data entry type of jobs. So they managed human resources quite well, and they also made a lot of investment in the human resources as well. And lastly, in terms of R&D, Dr. Kim mentioned that Korea is kind of lacking in terms of R&D and data accumulation and record keeping. But in Europe, they have accumulated a lot of data, and they are even very close to developing COVID-19 indicators based on their data as well. And they're active in R&D as well. And of course, Korea is proud of what it's been doing so far in terms of response to COVID-19, but still we have a lot to learn from European countries as well. And as just as Professor Kim mentioned earlier, I believe that we also need to take the lessons, our lessons from Europe, and incorporate that into our policy. Thank you very much. So today we talked about K quarantine in the face of the third wave of COVID-19, and we discussed the pending issues, and we talked about how to deal with the current wave of COVID-19. And we even listened to the European experiences as well. So although Europe didn't respond well initially, but over time, Europe really stepped up and did a great job. And also their infrastructure in terms of the hospitals and the human resources was a key factor. And now we are hearing about news on vaccine development. So going forward, we need to have quality data to further our research. And also, more immediately, what we need is, just as Professor Yoon Kim mentioned, we need to have a more hospital beds, approximately 10% more at national university hospitals. So we need to increase the number of hospital beds. That's a more urgent need that Korea needs to address. And also in Korea, the neighborhood healthcare center, that is kind of a backbone of the public healthcare system in Korea. And a lot is really lacking at a neighborhood or local healthcare center. So, for example, we need to dispatch medical professionals more to local healthcare center. And social distancing. We need to think about why there is a surge in the confirmed cases. So epidemiologists can hopefully identify when we can tighten our social distancing measures in order to prevent the number from going up further. So all these need to be connected well. So this is also not just about quarantine measures. Treatment measures need to be in place. Data needs to be accumulated, which can facilitate academic research into COVID-19. So all in all, well, we talk about Green New Deal. Maybe we can also think about Healthcare New Deal as well in light of this new infectious disease. So it's now time to close, but if any one of us has a burning comment that you want to make, I think I can accommodate one person. No? Okay? Okay. Okay, please keep your remark within 1 minute. I think you just summed up our session very well. And we here emphasize the need of R&D. In Korea, most of the R&D goes into new drug development and vaccine development. These are important, of course, no doubt. But we also need to have more R&D about COVID-19. And also, we need to think about the issue of fairness. And also, we need to think about the quality of medical care, medical services. So I hope that we need more R&D support targeting COVID-19. Thank you very much. So we've been here for about an hour and a half. So it was a short session, but it was very intense discussion we had. And I think it was a very substantial discussion we had. We have a representative from the Ministry of Health and Welfare here. So I hope that you can take our discussion point back to your ministry so that we can have a better policy and we can address the current wave much better. Once again, thank you all very much for your presentations and comments. So this will conclude the current session, K-Quarantine and Healthcare. Thank you very much.
Good afternoon. This is the section to discuss pandemic, the Corona-19 pandemic and the application of the AI to flatten this pandemic crisis. So this afternoon I have two speakers, Professor Park Tae-sung from Seoul National University, and also another speaker from the Sungkyunkwan University, Professor Baek Young-nan. And we have also discussant online, Professor Jung-hwa Park, and then he's going to join from the Ulsan UNIST. That's what we call in Korea. So I'll speak with some, I think, the introductory remarks, and followed by this presentation. And then Dr. Jung-hwa Park will be joining us as a discussant. And then we'll have some Q&A together among four of us. So I'd like to welcome all of you joining us by online. And we don't have any audience because of this pandemic. And then we have this recent surge in Korea, especially in capital Seoul area. So we decided just to go ahead without the audience, but we are very happy to have all of you joining the online. So let me briefly say a few words for this particular section as part of this Global Korea Convention 2020 that we started this morning. Instead of, I think, some remarks that I prepared, let me kind of put this in context of today's Global Korea Convention. This morning, we shared the so-called vision statement for the 2020 Global Korea Convention toward a world-leading nation contributing toward peace, co-prosperity, and sustainable development. And let me just, I think, to repeat a few words, I think, the remarks that may be very suitable to our discussion. This vision statement begins with the following introduction. Quote, with the outbreak of the COVID-19 pandemic, the global community is facing an unprecedented threat. The virus is spreading with no end in sight, while the economic crisis is accelerating. Inequality is expanding both between and within countries. And so we have presented 5 sort of objectives to accomplish this vision. And one of those, I would say, I would point to actually the third sort of goal that we decide to share with people in Korea and abroad. And it says, the third goal that we would like to share here is that we shall strengthen international cooperation and an alliance to expand global public good in the post-COVID-19 era. In particular, international cooperation should be promoted so that COVID-19 vaccine, a global good, can be used fairly by all. Furthermore, we must pursue reforms in global governance to reduce inequality in healthcare and work to enable shared prosperity. All stakeholders, such as governments, non-governmental organizations, and civil societies, must all collaborate in creating an international order of mutual and common prosperity so that the global public good is sufficiently well shared among all of us. I think this is actually saying pretty well what is the what the context is as we talk about I think this pandemic crisis with the application of the science that we can apply to this particular the surge. And let me kind of show you a few things as part of my remarks. And I think the two speakers will make their own presentation, but I'll just personally share some of the challenges and opportunities that we have actually grabbed in the past 9 months since this pandemic, I think, hit everyone on this earth. And I would say how we can nurture science tools and remain adapting to this new normal we all are facing. As you all know, I think everyone across this planet is struggling with this COVID-19. So I think some of the key authors have come up with this performance index for OECD countries in the most part of, I think, this year, as we all go through this crisis. And this particular index is constructed based on, I think, a few global health security indexes and some other, I think, critical measures, including reproduction rate and number of the death, and then other, I think, the health-related measures. And as you can see, especially when you see it, when you listen to this by online, you can see, well, okay, South Korea is actually among the top when it comes to this global health security index. By the way, this is constructed by, I think, this Sustainable Development Network Solution, the research group based in Columbia in New York. And there are many other countries in this top 10, I think, the countries that have done pretty well in terms of the health security. And it's not surprising, actually, Korea has actually got that spot among other, I think, leading countries. But you may be surprised, there are not many Western countries in the top 10. US, UK, and then many other OECD countries are not necessarily in these top 10 countries. And this, I think, very well, I think, speaks of how well Korea has done in comparison to other countries we call, I think, developed countries. So I'd like to just say a few things that we have done well in the past 9 months. First, Korea has done pretty well in terms of smart testing and tracing the patient or tracing those people who are infected and treating people in isolation to flatten the pandemic curve and sustain economic activities. I think my observation so far is that Korea has prepared pretty good legal infrastructure since Korea has gone through this the MERS outbreak back in 2015. So we actually had sort of this collective, I think, the good or the public good ahead of the individual gains. So this legal infra has been very important as we make some important, I think, the government decision for the public to actually respond to. And a couple of other things that we have done and then practiced in the past 9 months is that we try to have some near-casting based on the data. And third, we try to have some scientific interventions together with international science community. So we learn what are the good practices and best practices to control and harness this COVID-19 pandemic. This is actually, that particular law that we have actually institutionalized back in 2015 in response to MERS outbreak. And then we had some, I think, the smart quarantine info system institutionalized back in 2017. And then this year, we have used some big data system for precision tracing. And also, we could share some location data with the public evolutionarily, so we can have some, I think, the higher level of privacy over the time. The thing in the box is that actually the law that we have already institutionalized back in 2015 to have, a sort of very good legal structure in place so we can respond well in case of the crisis coming up. And that's what we have actually gone through this year. Let me show you just a couple of slides before I wrap up. So this is one example of how we used big data to see how people are moving from place to place. This is based on the SK Telecom mobile big data, about 30 million people, and we extrapolated. So we can see how people are moving based on their mobile phone location. This is the latest, actually, visual, I think, the visualized data of the mobile phone location. So in this case, we have actually traced all this mobility on the weekly basis since January 2020 up to, I think, this month. So now, what I can tell you here is that we have actually seen 18% of decrease in population movement after the latest surge. This is actually very important, I think, the data we can use, whether people are responding properly in response to the latest, I think, actually the upgrade of the social distancing measure, I think, demanded by the government. So here, another thing you can kind of observe is that mobility level is actually getting very close to the lowest level in the third epidemic wave of the, I think, we experienced back in August and then September. So we are going in the right direction, as you can see this data. And this is another thing that we keep, I think, keep watching. So how people are behaving in terms of mask wearing practice. And this is the pattern that we see in many other countries, and other countries actually following suit. So even a few countries that have not done it in the beginning of this crisis, they are doing pretty well, and they are using the mask pretty well, except a couple of countries like Sweden and then Denmark. So this is the example of the some model-based neocasting that we have done since last March. So Korean academics and then private sectors have been working together to use some SIR model-based, I think, the prediction, and plus some variants of the SIR model. So we can come up with pretty good, I think, predictions in the near future of this COVID-19 behavior. Just some, I think, the principle or methodology behind it is that when we actually do some prevention, actually we have, I think, some level of infected people at a certain level always. So this is very strange, but the more you've done, the better you've done a good job of the prevention. Actually, you have a lot of people are still remaining. So we have to continue working to control this COVID-19 pandemic. But one good actually insight that we can learn from here is that as long as we control it pretty well in terms of the impact of this pandemic and certain level of actually intervention, we can do so-called dynamic distancing. So as you see in this graph, there's a sort of some, I think, the small wave-like movements. And that is the sort of effect of dynamic distancing. What do I mean by that? As long as we can control this pandemic pretty well with certain the social distancing measure and then other restrictions, we can control it, and we can have some level of economic activities. And so we cannot actually go over certain threshold that public health can actually contain. And that is shown by that dotted line between that low wave-like lines and then this high the wave. So as long as you do not hit that threshold, the public health, the threshold, we may be fine. And that's what we have done well in the past 3 waves. But currently, as we go through the 4th wave of the recent surge, we are actually passing through that public health, the threshold we try to maintain. So we have to see how well we are going to do. I'm going to skip some of these slides, I think, as a demonstration of how we have done this kind of prediction modeling. So I think what I like to say in closing, we need the seers to do some good neocasting to predict pandemic curve. We need some, I think, the evidence-based practitioners. So we can come up with some good non-pharmaceutical interventions in balance with economic and social revitalization. Lastly, we need precision scientists who can actually use AI and then science to actually do some prediction and also have some good treatment of the patients. And that is actually topic of today's discussion. And so I'm going to stop here, and then I'm going to move on to the first speaker, Professor Park Tae-sung from Seoul National University. Oh, I'm sorry. The first speaker is the Professor Baek Young-nan from Sungkyunkwan University.
Good afternoon, ladies and gentlemen. It's my pleasure to have an opportunity to give a talk at this Global Korea Convention 2020. I'm a clinician. I'm an infectious disease doctor from Samsung Medical Center, 성균관 University School of Medicine. 강의 시작할게요.
So I'm going to start my talk.
Characteristics and the outcomes of COVID-19. I will focus on the data from the Korean studies. I'll briefly talk the current status of COVID-19 and followed by the clinical characteristics, complications, and outcomes. Up to now, globally, about 67 million are infected, and among them, 1.5 million are dead because of COVID-19, and the case fatality rate is 2.3% globally. As you know, we are facing the third wave of COVID-19 in Korea, and as you see the left figures, the number of cases are steeply increasing, and we are not sure how big and how long it will persist. I think it will depend on the compliance of practicing social distancing by the people. These figures the COVID-19 status in Korea by regions. Daegu is the first epicenter of the first outbreak in Korea. As of November 20th, the number of cases in Seoul exceeds the number of Daegu. These figures are the COVID-19 cases by ages. The most common age group is young adults globally. It is almost similar in Korea and other countries. The right figures is from the United States, and compared to the United States, there are more persons infected among in their ages of 50s and 60s. In Korea, actually the elderly persons are a high risk group for the poor outcomes. Incubation period means the interval between the infection and the development of clinical manifestations. The incubation period of COVID-19 is known as average 5 to 6 days, and as long as 14 days after infection. And usually the infectious diseases can be transmitted after the development of clinical manifestation. In contrast, this COVID-19 can transmit the disease before the development of infection, usually 1 or 2 days before the development of infection, and it was the main problem of failing the contain the COVID-19 in the early phase of the pandemic period. This figure shows the clinical courses of COVID-19. As you see the bottom of the figures, most patients are experiencing the mild or moderate illness. Usually it improves within 10 or 14 days. And some part of patients are progressing to pneumonia in 5 or 10 days and getting worse to the critical release in 10 to 14 days. This blue line shows the amount of viral excretion. This virus is excreted in the early phase of the clinical courses. So it means the COVID-19 usually transmitted in the very early phase of infections with the very mild symptoms. Fever, dry cough, and fatigue are the common symptoms of COVID-19. And the other symptoms include headache and some other respiratory symptoms, including nasal congestion, sore throat, coughing, sputum, dyspnea. And the general symptom is myalgia, arthralgia, chills, and gastrointestinal symptoms, including nausea, vomiting, diarrhea. And severe cases can have a higher fever than the mild cases. A study from Korea evaluated the clinical course and outcomes of 3,000 patients, accounts for 26.6% of total patients at that point. They divide the patients into mild, moderate, severe group by the severity scoring. Most of the mild patients on admission, about 5% were moderate and 2% were severe cases at the time of admission. The common symptoms were fever overall, and followed by sputum and myalgia like that. And in severe cases, have more fever and sputum and myalgia, dyspnea, and altered mental status like that. Among the studies, about 32% had pneumonia, depends on the severity. Severe patients has bilateral pneumonia more likely. During the admission, the patients aggravated the severity. Among the mild cases, 2.2%, and moderate cases, about 9%, aggravated to the next stage at the time of 14 days after symptom onset. And day 28 mortality rate was about 7.7% among moderate cases and 22% in severe cases. So, but there was no mortality case among the mild cases at day 28. Acute loss of smell and loss of taste was commonly found. In the study from Daegu, evaluate the prevalence of acute loss and smell or taste. About 15% had anosmia or agusia by the evaluation. And about 7 days, the median patients were improved their symptoms, and for 2 weeks or 3 weeks, the symptom was almost gone. In the study, they divide the patients by severity. As a whole, the mild cases was most common, about 83%, and 12% were classified by moderate, and 4% were severe or critical. This classification is basic data for the modeling, so I show you this data. Laboratory abnormalities are lymphopenia and elevated aminotransaminase and elevated lactate dehydrogenase level. Also, the inflammatory markers are elevated, and some coagulation tests have the abnormal findings also. As I told you earlier, pneumonia was found usually about 30% of cases, and the chest X-ray can miss the pneumonia finding in the early cases or mild cases. So chest CT is more sensitive to detect the pneumonia compared to chest X-ray. The right figure shows the very typical finding of pneumonia on chest CT. Some patients have the clinical complication. The respiratory distress syndrome is the most common. Also the renal failure, cardiac failure, cardiac arrhythmia, and some thromboembolic complication, including pulmonary embolism and acute stroke, can occur in the severe cases. Case fatality rate is high among the elderly patients. So it is about 20% in ages of over 80, and 7.1% in 70s, and 1.25% in 60s. And the case fatality rates are lower in younger groups. We evaluated the risk factors for the mortality or respiratory support. The higher CRP level above than 8.0 milligram per deciliter at the time of admission was strongly associated with the respiratory failure or mortality. A study based on the Korean National Health Insurance big data evaluated the correlation of comorbidity and the mortality in patients with COVID-19. The study shows the diabetes mellitus and heart failure and renal failure were highly associated with mortality. In summary, Korea is the third wave of the COVID-19 outbreak, and containment is difficult because of asymptomatic or pre-symptomatic transmission. And the incubation period of COVID-19 is average 5 to 6 days. Usually symptom improves after 1 to 2 weeks in the most of patients, but the part of patients experiences progression to pneumonia within 5 days and respiratory failure within 10 days. Mortality rates are increasing with the age, 20% in over 80 years. So I'm going to start my lecture wishing you stay home safely. Thank you.
Thank you, Professor Park. I think this is helping us to put things in context. So the next speaker, Professor Tae-Sung Park, will talk more about this prediction of the COVID-19 patients based on some, I think, the important correlates and using the machine learning, I think, the approach. So, Professor Park, your turn.
Okay, 시작할게요. Thank you for Dr. John for giving me this nice opportunity to present my work here. And the title of my talk is Machine Learning-Based Prognosis Prediction of COVID-19 Patient. So I will give a brief introduction, and then I will introduce our data set, and then I will introduce what we have done so far, including 5 different specific aims. And then some final concluding remarks will be followed. Okay, I think Dr. Kyungnan Baek showed this kind of pictures already. Okay, so the left one is the daily confirmed cases globally. And the right one is the one in Korea, and we are actually finished the second wave and we are moving to the third wave. I think the top on the right graph is about 600. Now we are very close to reaching the 700 today, actually. And these are the daily deaths all over the world. Is the left graph. And right graph is the daily death in Korea. And actually, it is the 7 days average, and we are reaching around 3 deaths per day right now. And this is the graph, COVID-19 trend worldwide. How long does it take for COVID-19 to stop? I think the same numbers were presented by Dr. Beck. And our current confirmed case is about 67 million. And now we have over 1.5 million deaths. As you can see, we have all the red ones all over the world, right? Especially in North America and also Europe is getting serious, and also India is getting serious. And also we are actually suffering like in the cold weather. The winter COVID surge is the worst event that this country will face. White House as Advisor Brooks said. Okay, I think some of you may have seen this kind of pictures. This was actually happened in this April. The picture is from India, and also we got some problems in Japan and also in Europe, right? And also similar problem happened in Korea, in Daegu, when we first encountered these ones. But a lot of specialists focus about concerns about this kind of COVID-19 situation will be very long. So we have to prepare for the explosion and the reunification. But actually it happened. Now we have about over 600, 700 new confirmed cases, right? Okay, what kind of this kind of rapid increase in confirmed case causes? Okay, what kind of problems can be broken here? So this is the well-known story, this confession from one of the atheist doctors from Lombardy in India. At first, few people were brought to hospital, then a few dozens, then a few hundred. Now we are no longer doctors. We are just ones sorting labels, deciding who can live and who should be sent back to home to meet death. Even if they have been faithfully paying taxes for the country for their entire life, they are sent home to prepare for death. Now we can confess, as human beings, we have reached the limit where we can no longer do anything in this situation where thousands of people die every day. I realize my uselessness on this earth now, but I want to give my last breath to help others. I just found this picture yesterday, but I think there have been some debate about this is real or not. I mean, his name is good, right or not. But when I first read this kind of article, I was very touched. Okay, and then I think about what would be the clinical characteristics for this COVID-19 patient. So when I first started this kind of problems in early spring, there are several challenges in dealing with COVID-19 patient. Like, for example, sudden worsening of COVID-19 patient with very mild symptoms, but it's very unpredictable. And there are a lot of asymptomatic patients, right? And so far, I think, as you know, there's not many active treatment, only one approved treatment, remdesivir, but it's not as much effective as what actually expected. And the vaccine is coming, only one in UK is approved, but I think a few will come soon. And also there are many cases for reinfection of the COVID-19 virus. And also there are a lot of side effects, after effect is getting serious these days. But these are very challenging issues. It's quite different from the other infectious disease, right? And at the spring, after receiving this kind of news, we think about what our lab can do for fighting with COVID-19. So it's kind of very challenging problems. So I like to contribute something with my students. So this is what our group have worked so far last 20 years actually when I first started looking at some micro data. So our group have developed many different statistical methods and models for working on precision medicine. So the left is the very different kinds of data set. For example, we are dealing with clinical data from the patient, and also we are generating a lot of genomic and transcriptomic data, and recently we are working on a lot of microbiome and metabolomics data. Our main goal for applying like the statistical model and also deep learning AI-based model is to provide some useful tool and prediction results for the clinical application. For example, we like to do something about to make predictions for drug response, and also we like to make some prediction about the prognostic, and also we like to do something about the recurrence prediction, and also we like to do something about early diagnostics, right? So what we can do from the left side to the right side to the real clinical application. So our group have worked a lot for choosing some markers of interest, because the left side is high dimensional data and we need to select some predictors to make some predictions. And for the chosen markers, we have built several models based on statistical models and machine learning based models, right? So that's what we can do because we have worked on this part for 20 years. And I will give you just one example. Our group has working with some like the pancreatic cancer data set. And here the intraductal papillary mucinous neoplasm, we call IPMN, is the early stage of pancreatic cancer. It can be like malignant or not. So before making any resectory, it's very difficult to decide whether it's going to be cancer or not, right? So we had a chance to work with the medical doctor working on this area. And we identified some markers of importance, like the age and some certain marker values. And then we developed this kind of prediction models, and we make the software available. It can be easily run on our web site. So each values represent important markers, and each bar shows how much that each predict can contribute the overall estimation of the probabilities, whether it is malignant or not. So this kind of model would be very popular, and I just found out that we upload this nomogram in July 2018. It's been a while for more than 2 years. And last week I found out that like as of December 1st this year, more than 70,000 users from 62 different countries, right? As you can see, a lot of users from the Korea and Japan and like China, and also a lot of users from the North America and Europe, right? So I didn't know that this kind of nomogram has been so popular in this pancreatic studies. So I was very proud of it, and I like to do something, similar things for the COVID-19 situations, right? So in this spring, we thought about how we can do for COVID-19. So we prepared this kind of diagrams. The left part is the data set from the COVID-19, right? So for each COVID-19 patient, we got some initial symptoms, and also we got some epidemiological information. And while he's hospitalized, while he's being treated, we continually collect some clinical information, right? So those are going to be our input, right? And then from those data sets, we can select some markers of interest, and then we can build the prediction models. So what we can do using those models, so after discussing with some infectious disease medical doctors, we decided to work with the maximal clinical severity score, and how long this patient gonna last in hospital, for example. And then third is clinical severity score pattern and drug response, and asymptomatic and patient unrest kind of things. So for this COVID-19 project, our final goal would be prognostic analysis of clinical data from COVID-19 patient, and our specific aims are follows, 1, 2, 3, 4, 5. So I'd like to go through one by one. We are lucky to have a chance to work with some COVID-19 data set. The first data set what we have worked with is from Korea Disease Control and Prevention Agency, KDCA, right? And this data set, we were able to analyze about 3,000 patients. And the last follow-up date was May 29th. And we started looking at this data set from the middle of April. And because some restrictions, we have to visit there with my students to analyze this data set. And fortunately, we have a grant from KDCA to make this analysis. And also the Korea KDCA made some public data available for the researchers. So about second day is about total of 5,000 patients. Okay, and the last follow-up date was April 30, 2020. And we were only allowed to make analysis for 2 weeks actually. And then we asked to 1 more week. So we had to finish this analysis for only the 3 weeks. And we were very quick to make analysis, and we prepared 1 draft, and it's under review right now. And while working with the first data set, we had a chance to work with the Professor Shin-woo Kim. He's also the infection disease specialist. He played a very important role in Daegu situation, and he greatly shared his data set about 2,200 patients collected from Daegu hospitals, and we will analyze this data set. Okay, but unfortunately, the first data set is not allowed to make any presentation or publish any results. So in this talk, I will focus about 2 data sets: KDCA public data and Daegu data set. Okay. So in this data set, we have some initial variables like height and weight, and some demographic, and some clinical findings at admission, and some comorbidities. And also we do have some daily data sets available. While they're in the hospital, some measures are continually obtained, right? So we have some clinical severity scores there, and also some lab tests are available for these 2 data sets. Okay. So these are the structure of data set. And these are simple comparisons. When I prepared these slides, we freeze the data like May 12th. So KDCA represent, the last one is about 3,600 patients, the total Korean COVID-19 patient. And the pink one is about public data, and the sky one is the Daegu data set, right? So left table shows the overall frequency. So it looks some different. But if you look at its proportions in terms of the age, so they are very still very similar, but except that only Daegu data has some older people, right? And this is the gender distributions for the male and female, right? If you look at the proportion, they look very similar, and especially we have more data for the female patient, right? And let's look at specific aims one by one. The first one is the maximal clinical severity score predictions. And for this analysis, we use 2 data sets, KDCA public data and Daegu city data. Okay, what is our goal? Our goal is to develop models for predicting maximum clinical severity, and we call it MaxCSS, based on initial and some epidemiological data from COVID-19 patients. So what does the maximum clinical severity means? Okay, for example, one patient entered this hospital. His condition was mild, but he moved to moderate and then severe, and he became very critical, or become mild again, right? So he goes through many different CSS levels. But when we say the maximum CS, it means the one with the worst CSS values, right? So each patient has only one max CSS values, right? Okay, this kind of analysis has been done by many researchers, right? For example, some Korean researchers used this kind of analysis already with a small data set. And when you look at their outcomes, they focus about the severe status like ARDS or the ICU admissions, what has kind of things. So they focus about the binary outcomes. And I've found that there are many publications using the Korean data set. And also the military doctor, Dr. Her, I think, published some papers about using the similar type data set, and he based on the models. So the pink one represents the models. Most paper has been published using the logistic regression. My second paper, XGBoost, is based on deep learning models, right? When we first received this data set, the KDCA provide 8 different CSS levels, right? One is the most mild one, no limit of activity. 2 is the limit of activity but no oxygen therapy. 3 and 4 is the O2 with no nasal prong, so it's a very light oxygen supply. And 5, 6, 7 is like very strong, like ventilation kind of therapy, and also including ECMO and death, right? So as you can imagine, like handling 8 different levels is very challenging. So we collapsed those levels into 4: is mild, moderate, and severe and critical. Okay, so for the mild part, we used no limit activity for KDCA, and moderate means limit of activity but no oxygen therapy, and severe is light oxygen therapy, and critical is high flow oxygen therapy, right? But when we're working with Dr. Shinho Kim at Gyeongbuk National University, he suggested using some temperature information. So we use a little bit different mild, moderate definition, including temperature data set, right? Okay, so this is the distribution of our data set. For example, KDCA, mild is about 4,400, so about 80%. Moderate is about 6%. Severe is 9%, and critical is 5%. But when we use the temperature information, then, for example, in Daewoo data set, we'd have a 30% mild and 40% moderate. Okay, and severe and critical is a little bit different, right? So a lot of people from the mild tend to move to the moderate groups when we use the temperature information, right? For this 4-level data set, we tried some simple analysis. That's why we just combined them. The first analysis, we look at the mild versus others. Second is we combine mild and moderate as one group, and then above severe as one other group, right? And 3 models, we focus on critical, and all the others remain in one group, right? So we consider 3 different models, right? And the model, what we considered is that like we tried logistic regression model, like in terms of the success probability, we have the S-shaped graph. And then we can try the random forest is based on the tree-based models. And by generating some bootstrap data set and also aggregating some voting, they provide some well-improved prediction results. And also, as you can see, a support vector motion is a very well-known classifier. For example, if we want to combine the red and the green ones, then we can define some hyperplane, right? And deep neural network and guide is a new one, what we actually tried. So as you can see, we tried the deep neural network for this data set. It contains like our input and output, right? Our input data would be some clinical information from the early stage of the COVID-19 patient, and outcome will be some classification. Like we can use 4-level classification, or we can use 2-level classification, but we can put many different layers, to improve the prediction performance. And also the guide was actually proposed by Professor Wei-In Lo. Actually, he contacted me to work with our Korean data set in March, right? But it takes some time to get the data set. So after getting some Korean data set, when I contacted him again, so he's not interested in our data set anymore because he had a lot of 50,000 American people, like he's working on that data set analysis, right? But I think his model, like called it like a guide, is very useful. It provides very intuitive interpretation of the result. Okay, so we tried these ones together. Okay, the first analysis was about, we look at just univariate analysis by focusing about one variable by one. And our outcome is max CSS with 4 levels. As you can see here, the age and body temperature and BMI, heart rate, and SPP, like the positive related risk factors. And also male has a chance to have higher CSS levels. And also like some comorbidity variables like diabetes and hypertension and so forth. So those are very well-known risk factors. And for this data set, we perform like a very detailed statistical analysis, but they provide very consistent results. And also for Daegu data set, we did the same analysis. So we identify some risk factors using initial vital signs and clinical findings and some other comorbidities. And also, some patients have some X-rays on the CTs. Those are also very informative. And like these ones. Like for example, if we look at some simple draw for each age, like x-axis and y-CS values, and you can see this kind of linear increasing patterns, and it can be found in our data set. And also, if we look at the sex, like then like male tends to have, no, I'm sorry, female tends to have the more severe CSS values. And also, for example, when we look at the shortness of dress, then you can have this kind of symptoms, then it has high chance of having the high CS values and so forth. So each value can be interpreted similarly, even like, for example, diabetes. You can look at the right side is yes, left side is no, right? If you look at right side, yes, then he has more chance to have high CS values and so forth. So this kind of graph can be easily interpretable. And when we look at this data together, we got 21 commonly identified from 2 data sets. So those are very informative risk factors in our analysis. And then using all data sets available, we built some prediction models in using multiple models here. So we applied logistic regression, and also we applied random forest and support vector machines, and also we applied DNN, deep learning models, right? The last column shows AUC values, and as you can see here, when we use the Daegu data set, our AUC value is like 0.935, right? That's the highest AUC values I have ever looked all the other literatures. So it provides very good predicted results. And when we compare the mild and moderate versus severe and critical, we got some performance, but its prediction is a little bit lower. And also when we compare the others and critical, it also very good predicted values. Like for example, KDCA public data set, we do have like AUC 0.944, right? Very good predicted, well predicted result, right? And this is the guide result. But this performance was not that good, but it provides very intuitive result here. And based on this data set, we built nomogram for, this is the for KDCA public data set, okay? So if you put some numbers for each selected markers, so it's moving right now. And we have 3 models. We can choose one model. Oops, and then, oops. Okay. And then you got the results. It's very fancy results. It's on our web page right now, so you can use it if you want. Second topic is about clinical severity score patterns, right? For example, one patient goes mild, moderate, is okay. Second patient goes mild, severe, and mild. Third patient goes to moderate and critical and moderate, right? So we are interested in looking at some trajectory of each patient, right, based on CSS. And then we are interested in looking at some predictions. If one patient came is like the positive results, then what would be his like trajectory for CSS, right? So that was our analysis, and we look at some Daegu data set, and we identify some patterns. And we also identify some risk factors, and we make some prediction values here, right? But in this case, we especially focus on about those who have only the mild symptoms. So based on these ones, we also finished program, and it's on our web page right now. Okay, so this is also movie. Okay, but if you look at the bottom, there is our web page site. You can look at it. Okay, it's very slow. Okay. Now our third topic is the treatment period time, right? Do you remember that how many days the Daegu patient 37 stayed in hospital? I was told that she stayed more than 120 days, right? But some other patients, famous patient like Pastor John, he stayed only 2 weeks, right? So it would be very interesting how long each patient going to stay in a hospital. So we look at those data set, and we just computed those treatment period or the staying period in the hospital. Like we used the Daegu and KDC public data set from the initial to release, right? So we used two different treatment period for two data set, and we built the same models based on KDCA public data and also the Daegu city data and based on the time, right? And also we just compare those two results. And then what we did is that we just look at some binarized the data, long period and short period, right? And then also we do the same analysis using the logistic regression models, okay? And the first topic is drug effect analysis, right? And for our data set, we had a chance to look at the collateral and hydrochloroquine and steroid. And also we have some chance to look at the remdesivir for KCDC data. Okay. And while looking at this data set, we found that there are some differences in terms of each patient staying in the hospital, right? So some drug has the effect of reducing the treatment period, and some are not, right? So we just compare those two results. And also we developed some others, like for example, the column represent the before treatment and row represent before treatment and column represent after treatment, right? So each patient started mild, then he become mild is 23. This mild become moderate, and mild become severe and critical and so forth, right? So diagonal numbers are unchanged, but on the upper diagonal part is the worst cases, and the lower diagonal numbers are the improved cases. So by comparing those numbers, we were able to compare the drugs. So we got some result here, and also we just compared before and after treatment scores. Okay, so this is the results. And finally, we're looking at the asymptomatic patient, right? But this data set, we look at the Daegu city data, and the total data is about 7,000. Among them, like 5,000 are from the residential treatment center. So they have only gender and age information, no clinical information, right? But we know that they are asymptomatic patients, so we just look at them. So data will be asymptomatic patient who have no symptoms in the residential treatment center, and we just compare them with the symptomatic patient, right? So this is, if you look at these ones, like this Kaplan-Meier plot, and they show some differences here. Like if you look at the median, the asymptomatic patient stays about 24 days, and symptomatic patient about 27 days, although there's not that much difference, but the difference is significant. And if you look at this age, it's very interesting, right? So the first line represents the age under 20. So if you look at those two numbers, 0.58, 0.42. So asymptomatic patient rate is about proportion of 40%. But 20s, it becomes 40%, 30s, 33%, right? As you can see here, as age gets older, proportion of asymptomatic patient reduce greatly, right? So you can see those kind of patterns. So that's actually what we observed in our city right now, right? And also if you look at the male and female, there are more proportion for asymptomatic patient in female. Okay, that's not what we actually expect, but it has happened from this data set, right? So I'd like to conclude my talk. So in this presentation, I just briefly go through 5 different specific aims using actually 2 data sets, but we also have the 1 data set from KDCA. Okay, so this is what we actually had so far. And hopefully, I hope this kind of work can be used in real clinical application for fighting with the COVID-19 patient. And we do have some progress about in scientific area, but I think our work hopefully contributes some like real practices. That's what I want. And when I look at this data set, I think our data set is a little bit old. Like the Daegu is August 30 is the last follow-up, and KDC is about April 30, so right, pretty old. And when we look at this data set, a lot of NAs in clinical data, and also there are some limited number of clinical variables, and also very challenging in some data integrations, right? So it reminds me some fundamental issues, right? The data should be updated. As you can imagine, the more data, the more accurate predictions, right? And also data quality is very important. As you may have heard about garbage in, garbage out, right? So the quality of the information coming out cannot be better than the quality of information that went in, right? So good quality of data would be very important. So first thing what we can do is some kind of data standardization to deal with COVID-19 patients. And we are dealing with the retrospective studies, right? So I think if we pay some more time and if we design well, then I think high quality of clinical data can be obtained by designing some follow-up kind of studies, right? And also, I think it was very important issues for effects of COVID-19. So this kind of design would be very important. And I think this kind of thing can be done by government, right? So I think the standardized protocol for COVID-19 would be very important. Okay, so this has been done with my some statistical groups and also some clinical team, Dr. Kim and Dr. Oh and Dr. Moon, okay? And also I worked with Dr. John here. And I'd like to thank all my students who worked for COVID-19 clinical team. They worked very hard. They worked very voluntarily. And also our group has worked on some modeling team. Some of the results has been shown by Dr. John. Okay, so this is one part that we are working right now for modeling. And also, I think Dr. Jong-hwa Park will talk about some SNP data, and he's very interested in generating the SNP data, and also I'm very interested in looking at this data set, and our group is working on some biobank SNP data for COVID-19 patients. Okay, I will stop here. Thank you.
Okay, thank you, Professor Park. I think I gave him more time than planned, because we have this worldwide online audience. This may be the first time that he shared this important AI-based, I think the COVID-19, I think the research. So hopefully more people can listen to this afterwards. So let's turn to our discussant, Dr. Jong-hwa Park with UNIST. Dr. Park, will you join us to share your discussion points? You have 20 minutes. Oh, I'm sorry, you have 15 minutes.
Thank you very much. Actually, so today this is about prediction, the prediction of the future and possibly future pandemic disasters. So I'd like to cover some social aspects and technical aspects, and finally, how government institutes can cope with this kind of thing. So first, I think this coronavirus is the situation we have is mostly human disaster. I think that's something we need to remember, because a lot of collaborative networks or systems in the past have been kind of broken down before this pandemic. And that's why there was actually lack of communication among scientists who could check the original data and how we can cope with all this viral infection and so on. Anyway, so it was a human disaster and it expanded really rapidly. And some countries, managed to cope with this. Some other countries failed miserably, and unfortunately, a lot of people died for that. So the answer or the core of the problem started as human disaster. But in my opinion, the most important aspect of dealing with this properly was science and technology. So some countries relied on data, predictions, computer algorithms, simulations, and so on and so forth. And while some other countries actually believed in their, in a way, confidence, faith, they had a belief system on how they can cope with this kind of thing. So there was a huge, forking point where science was used widely. In some of the, countries, it was not the case. And underneath of this science and technology, in my opinion, the most important aspect is democracy. The government, the society, and each citizen contributed to the level of democracy in practicing this democracy in terms of communication and how actually we collaborate to each other. So the social distancing was mostly successful in Asian countries where people conformed to the idea of public wealth, safety. So I think that was very important. And Korea was a model case where people, the public, responded really well. And unfortunately, still we have three instances, three big waves of this virus. The cause, unfortunately, was totally social and mostly done by sabotage of the people who actually didn't conform to the constitution, the social rules, and they actually actively sabotaged in certain cases. In August 15th, these certain religious groups really actively went against the policies and the social well-being, and that was a disaster. And that actually lingers on in such a way that the third wave is firmly standing on the second wave, spread all across the country. Very unfortunate, helped by the weather, climate. And to deal with this thing, we need more than coronavirus kits, PCR kits, and some tools. We need social infrastructure accompanied by or helped by science and technology tools. So there are two things. So the future relies on, in my opinion, heavily on these two things. One is government infrastructure, where they can force with power, the power given by the public, on how to manage certain groups of people or certain sectors of society, people who go against this kind of scientific paradigms, where they actually refuse to wear masks, where they refuse to avoid a meeting or gathering together for certain purposes, whether it is business or religion or whatever. And that can be enforced, in my opinion, or we can persuade the people only using scientific data helped by statistics. So in that sense, Korea's success so far suppressing the pandemic is based on a lot of people's data, as two presenters presented here on the data and how they actually presented very openly, transparently to the public. And then they made predictions. And this will help the government, the top government officials. And again, this was followed by, in my opinion, very diligently by the medics, the people who actually confront the situation locally, who help the patients, who manage the protocols, from the airport to their homes, and so on. And a lot of these procedures, complicated protocols, were assisted by technologies, IT technology, mobile phones, computers, all this GPS on these things. And government actively used those things. Anyway, so the core of the problem was a human disaster, mismanagement, and solving the problem was mostly from rational democratic decision-making and scientific infrastructure. Now, let's move on to the future. Now, we are confronting a situation where we have to release vaccines to inoculate people as many as possible, as in United Kingdom. And what kind of scientific data do we need? First, a lot of cases, the mistakes we made all across the world was based on false data. So, for example, people talked about the effectiveness of mask, which is ridiculous as a scientist. How can you actually even deny, this physical tool, in front of, right in front of your mouth, actually preventing this airflow? I mean, absurd. And there was argument going on early this year. I couldn't believe, some medical experts talking about the effectiveness of this kind of thing. And again, this happens, in my opinion, even right now. Early this year, people talked about the effectiveness of the vaccines or the danger of vaccines. I was really appalled to hear those. Vaccines, you think about vaccines is not even a drug, cancer drug, or it's not even a treatment. It's just a vaccine, which is just piece of viral, particles, and we actually normally every day we inhale those tons of viruses, bacteria every day. Those are kind of potential vaccines, and a lot of people are afraid of actually approving these. And funny thing was the most less democratic countries such as China and Russia, supposedly, those people were ahead on this kind of thing. So I'm not saying we have to be we have to rush to take those things. But what I find it unfortunate was there was no playground or ground where experts and the policymakers and scientists gather together to talk about these facts. What are the facts? What are the scientific infrastructure? What are the principles here? And I didn't see those, even in Korea, unfortunately. But we were fortunate. Another thing is, Professor Park and Professor Peck talked about the data and predictions and so on and so forth. And as a data scientist myself, I was very frustrated, even now, by the lack of communication among the government, the database analysts, and the hospital who collect those data. In Korea, it's quite hard to get those data. I don't know how Professor Park managed to get thousands of those data, but I tried to get those. It was very hard. I managed to get certain samples in the early stage, and then it was really hard. And I contacted Ulsan City, where I live, and it was really hard to get those data, not only because lack of this communication, but it's a miscommunication as well. So a lot of these people who got infected were afraid of cooperating with the government and the city officials and so on and so forth. They were essentially they were the victims, but at the same time, there was a social stigma as well. And that was very sad because those people can help, finding solutions efficiently. So although we have this, really good group of expert group of bioinformaticians, statisticians, and scientists, we couldn't use all the data generated, collected by the government hospitals effectively. So, as you know, in UK, that was very efficient. They, had this consortium, and then they started to sequence really fast early. They are sequencing a lot of the people who got infection now, and I think next year we'll have very interesting scientific results from those groups in the UK. Anyway, another thing is, after all this, so Professor Park presented his algorithms using neural nets, random forests, all these prediction methods. I'm sure he used Bayes, all kinds of interesting and advanced algorithms. What I suggest is the government, CDC, Korean CDC, needs to accommodate all these programs and expertise results and put them into public resource in the future. So we have to make a systematic infrastructure pipelines in CDC, Korean CDC, in a way that whenever we have this influenza or coronavirus or even an unknown new pandemic, we should have a very organized system of collecting the data, sharing the data, and automating the analysis in such a way that the government officials, high-ranking officials, can get the predictions really fast. So Dr. John, of the head of the Korean Statistics Institute, Dr. John Young here, who is the host of this show, the session, and he has been actually delivering almost manually. So he has been coordinating with a lot of professors and some researchers in Korea, asking this data, that data, prediction models using these Canadian experts and so on. So in a way, he was kind of playing, almost as a one player, coordinating all this like an orchestra. So that was interesting. I appreciate that. And we should make this system automated, much more systematic, in such a way that we have data collection, sharing, processing, and applying AI, deep learning or whatever these technologies, and then we churn out all these predictions, R values or future R values, and some social distancing parameters and these things automated. And I was surprised actually we didn't have that system because it happened to be my field, and so I would expect that such a prestigious institute in Korea should have that kind of system, or at least they should have supported the scientists in such so that they can show those. Anyway, my last remark, the Korean lesson, all these is. And the responsibility of the government. When the disaster struck, the most important player, whether we like it or not, is the government. And government needs to be brave. People gave power to the government, actually for this kind of occasion. Of course, power is dangerous. It's always dangerous. When you abuse the power, you can actually sacrifice democracy or everybody's rights, human rights, whatever. But at the end of the day, power, in my opinion, whether it is expressed as a scientific power or money power or financial power or whatever power, I think that's what the public wants. So I hope that the government will go brave and adamant in keeping the order in such a way that we don't accept nonsense. We don't accept this anti-social behaviors, sabotages. Secondly, the government should be also brave in taking the responsibility for companies. The vaccine factories. They want to give their kind of vaccines, but they are afraid in a way to get the responsibility of side effects. And also the scientists as well. Scientists need to want to get the data. Possibly infringing some privacy, personal, information, and so on and so forth. And at this point, government should be brave in that approving those test kits, approving vaccines, and approving data sharing, and they should go ahead, in my opinion. Why? Because they need to use science and technology, because science and technology is the only powerful tool we have. And I hope the whole Korean government, the many ministries of government in the future will be much more brave in embracing science and technologies and actually giving power to the authorities and scientists, and eventually making this science innovating, science-driven, data-driven system against pandemic. Thank you very much. That's it.
Thank you, Jong-ha Park. I think I like the background he has behind him. That is I think the shining the universe. That's what I actually watched a second ago. I don't see it anymore. You're gonna give us 2 shots. Oh, okay. Oh, that's good. That's better. So I felt like I returned to London. So that's another reason I enjoyed listening to Dr. Jong-ha Park. So I spent a few, I think the moment, some time back in London when I was younger. But anyway, I think we had pretty good, I think the coverage. Starting with this good, I think the coverage of the foundation, medical foundation, clinical foundation, Dr. Kyungnan Park shared with us. And then we moved on to this discussion of how machine learning, deep learning of the AI can be a good tool of predicting the status of the patients in advance. So that is what Dr. Tae-sung Park shared with us. And then I think our discussant I think has very energetically shared with us sort of this large sort of context. Sort of, this is the human disaster, and there are roles the scientists have to play, and also the mission that he actually recommended to the government. So we covered a lot of things in a very brief moment. I think Dr. Jong-ha Park has not raised any particular question to the presenters, but let me be very open to both presenters. This is the moment, perhaps I'd like to give to Dr. Park first to comment on comments, if you have any. Also, Dr. Park, if you have any comments on comments, I can come up with my own questions, but at first, I'll make it open. So, Taesung, if you have any comments that you heard from Jonghwa, would you like to go first?
So you have no question to me? Okay, I think it's very impressive speech actually, right? I think I'm focusing about some of the issues what I'm dealing with and some of the data. But I think Jonghwa Park has some intuition. He is looking at some big pictures, right? So he raised very fundamental issues what we are dealing with right now. Like we are dealing with COVID-19 situation we have never ever experienced before, right? So far, I think our government is doing okay using the 3T. And now we are talking about some precision like kind of things. We like do the same strategy for medicine to like the infectious disease, right? But while working on this kind of new situation, we are still very struggling, right? So what we have to do is that we have to work with together in one big system, right? As the Jonghwa mentioned, we have to share our ideas and what we learned. So we have to find out what we can do together for the future, for the fight with COVID-19. So I think as a scientist, it's very important to share what I've learned so far and what I have right now. So it can be very useful to other scientists. And especially, I mean, the sharing the data would be very critical issue, right? And I've worked with the KDCA, right, people, but they are very reluctant to share the data set, although I'm very lucky to have a chance to working with them and have a chance to looking at the data set. But I got only the early, like the May, and I wish I'd like to look at some other more recent data set because it's changing a lot. It's changing very rapidly. If I had more data set, I would be able to get some more predicted results. That's what I want. And also to work with the government people and the scientists would be very important. So the fundamental thing we have to do with the communication, right? If we understand the other parties, then they understand our party too, right? So while working with together and while communicating together, I think we need to find out something what we can do together. But so far, I think the scientists and our government and have been doing okay right now, but we can do better. That's what I think.
Okay, thank you, Taesung. Perhaps before I move on to Kyungnan, let me just ask one question because I think you kind of suggested it. I had actually quite a few questions, but I'll just pose one. That is, assuming this model and methodology you proposed is going to be rigorously working. And you certainly proposed to the government, we need quality data so we can have, the better AI tools based on this quality data. That is the one suggestion. But what is the thing that you like to do, assuming everything is just working pretty well? What are the next steps that you wish to take? So this tool, this nomogram you developed can be useful.
Okay, actually, as a scientist, as a statistician, most people are very interested in publishing the result, right? And using their results, they are very interested getting some grant for their study. But when I first looking at this data set, I was aware of that I'm not able to publish any results, right? But I just want my analysis results would be informative to government people to make good decision to fight with COVID-19. That's all I wanted. But still, I think it was not easy to work with them, right? So that's why I could not get any further results since May. But as you said, if we get more data set, then I'm pretty sure that we can get more better predicted results. And my hope is that our prediction results can be freely used for any infectious disease clinicians, right? To make some predictions. And I know that some patient in ICU, they need not to be there because if that ICU is vacant to some other who actually need ICU very urgently, they can take that space, right? So we can use the kind of efficient space, ICU allocation kind of things. And that kind of allocation actually reduce a lot of medical costs. So if we look at together and if we use this kind of allocation of programs wisely, then we can do a lot of things, right? That's what I want. Right?
Okay. I think that you are actually suggesting a lot to the clinical people, medical community, and also perhaps a lot of people listening to this section online. If you're out there, if you are medical doctors, medical practitioners, you just saw the tool here, right at this moment. You know, you can speak to Taesung after this section, and then please stay in touch. And so we can actually work together. And actually, I really like this term that Jonghwa used. You know, perhaps I was playing a role of, orchestrating, a lot of different players. Actually, I used to be conducting boys choir when I was young. So I love to do team play. And that was, something I enjoyed a lot. Of course, Korea has a lot of talented, scholars, researchers, and then people with, quite a lot of different, I think, the wisdom. So it's been fun. It has been fun, this year to be working together. So I'll just stop there, but let me turn to Gyeongnan. So I think I gave you some time to think about comments about the comments that Jonghwa has made. So do you have any comments to share?
Actually, I'm a clinician and I'm not so familiar with this kind of modeling and especially the using the AI. Yes, and actually I learned a lot during this COVID pandemic condition. For this modeling and AI, and yes, and so I think Dr. Taesung Park and Jonghwa Park showed very informative data and very good comments to prepare and respond to the next pandemic. As you know, at the beginning of this year, we didn't know anything about the COVID-19, so we responded to the COVID-19 based on the knowledge got from the other disease and from the past. But during the first 1 year, we have many information about the COVID-19. So I think we can change our response more precisely based on this very informative data and knowledge. Yes, and like the patient allocation or some preparedness for the medical facility like that. Yes, yeah, I think this collaboration is very good to overcome this condition.
Okay, let me ask you just one question. As I was listening to your presentation earlier, and also the parts that I heard from Taesung and then Jonghwa. You're a clinician, clinical medical doctor, and you actually covered this foundation and foundational characteristics of this COVID-19 pandemic. And you talked about these clinical complications or the side effect, as Taesung noted. And then among those the clinical complications, you noted sort of this psychological effect of the COVID-19, such as depression, anxiety, and other mental, I think, the pressure. So my question to you here is that how, what would you suggest? What would you suggest to cope with this kind of, mental, I think, the illness, the depression, anxiety, as the, the symptom of this COVID-19, and then what kind of preparations we got to do, to deal with it?
It's a very difficult question. Actually, I don't know the answer. Maybe you asked me because you don't know the answer also. I think the psychological problems came from both because of disease itself or from because of the other secondary condition like the social stigmata like that. I think the second cause can be more responsible for the psychological depression like that. So at the beginning, we gave the bad stigmata to the infected person. So, as you know, we can be infected anytime, at any place, even we can't notice if it is dangerous area or not. So, I think we have to change our thought. This is a kind of disease, just a disease, and they are just patients, and we have to accept the patients as a victim, not. So yes, they can be more helpful to the coming out of the patients to the society. Yes, and they can be if with our thinking. So this changing, they can. I think more patients can be easily tested if they have the infection or not. So maybe we change the word is confirmed cases. Instead of confirmed cases, we call them just a patient who are infected person. Maybe we have to change our words first.
Okay. Just like you said, this is not an easy question to answer, but I wanted to learn from your experience as a clinical the specialist. Part of the reason I asked that question, I'm aware of this recent study done back in the States. When they followed up, a lot of these COVID-19 patients who are recovered, and they did a follow-up survey. And they actually found 1/3 of those recovered people actually experienced some kind of mental illness, depression and anxiety, things like that. So if that was the case in the States, it may be also true here in Korea. We have a lot of people recovered. But some of them actually have complained about some of this. I think the remaining the mental, the pressure and then mental sort of the characteristics. So we got to be prepared better for dealing with that kind of the symptoms, because depression and anxiety is very highly correlated with suicidal attempts in many countries, and that is one thing I'm very concerned about. And we got to be better prepared. If not, we may have, the more episodes of these suicidals in the near future, and we got to have some preventive actions here. So that's the sort of there's something behind. Would you like to add a few words? Okay, yeah, please.
Yes, I think even other people, not except the person, can have the mental problem also, like the depression or anxiety. Yes, so maybe the government should handle this problem also.
Okay. Before, I think we are almost close to the time to wrap up. But before I do that, I'd like to give 1 minute to each person, including discussant, the Jonghwa. You heard some of these comments and responses to some of the answers in the limited time. I'd like to give 1 minute to each person to wrap up your thoughts, and perhaps a few things that you'd like to reiterate, or some actions, or some the other suggestions that you have for this online community, listening to us, or the people out there, the other important stakeholders that I think we need to work together. So let me start with perhaps the Jonghwa. You have 1 minute.
Thank you. So my last comment is we should automate the experience of Korea in coping with this pandemic in terms of automating the data processing, sharing the patient's data, the 3T, and also how we can predict the outcomes of this, the R values and so on. So we should automate all this as infrastructure. Thank you.
Okay. Kyungnan, you have 1 minute.
Yeah, I think we have to change it differently from the past, and we have to modify our strategy based on the current status, and very rapid action is needed. And the very close collaboration between the scientists and the government persons are very essential to overcome this disaster.
Okay, thank you. Taesung, you have 1 minute.
Yeah, I think the more we can work together, the more we can achieve to fight with COVID-19.
Okay, that's very short and succinct. Actually, let me wrap up today's section. I have a little over 1 minute. I think this final sort of concluding comments I have heard from these the speakers and discussants reminds me of this first meeting, international online meeting that I had back in April with highly, I think, the influential, the experts around the world. And we got together online, about 70 people, in response to this call by CIFA, Canadian Institute for Advanced Study. This is the institute actually mandated by the Prime Minister of the Canadian government. Actually, they put together a lot of these experts around the world, about 70 people, and they talked about what should we do in the wake of this COVID-19 pandemic. This was back in April. They said, as I recall, the 3 things. First, we got to have collaboration. And that's what we heard today. Second, we need data, quality data, so we can work together, share together, and then help fight this pandemic with worldwide team play. It's not limited just to one country, worldwide team play. The last thing is more team and then coordination between governmental, non-governmental, and then other players all together. More collaboration in the near future. And that's actually what you heard from all of us this afternoon. So let's work together with those kind of spirits so we can continue to flatten this pandemic in the coming month. And just like all the speakers shared together with you, we are ready to work together with any of you listening to this section, and then we'll take next steps together in team spirit and with this Team Korea. And thank you, everyone.
Thank you very much.
Okay, bye-bye.
Bye.